So till now we are able to complete the this introduction part of the antiemetic drugs, physiology of the mechanism, or we can say mechanism of the nausea and the vomiting, normal mechanism of the nausea and the vomiting, classification of the antiemetic drugs, and antidopaminergic drugs, about the detail about the antidopaminergic drugs, serotonin receptor antagonist, and this antihistaminic drugs, prokinetic drugs. In prokinetic drugs, last class, I thought I would be able to complete the prokinetic drugs in the last lecture, but I was not able to complete that. But today only few slides are there for few slides are remaining for prokinetic drugs. So we will try to finish this today, and then we will continue over the next topic, some part of the next topic. Okay, so prokinetic drugs. So any confusion till now in the prokinetic drugs? Any confusion, any one of you till now in prokinetics? So we will continue our prokinetics. So in detail, I will again review. So what are the prokinetic drugs? So prokinetics are those drugs that increases the peristaltic movement, of the GIT. So when the peristaltic movement of the GIT is increased, so that increases or that speeds up the gastric emptying. So when the gastric emptying will be enhanced, what will happen? The gastric content will be entered into the intestine, and there will be impeding of the stomach. And beside that also, there's an increase in the tone of the lower esophageal sphincter. So what will happen? There will be no regurgitation of the food particles from the stomach into the esophagus, so that inhibits the nausea and the vomiting. How that happens? Prokinetic, so release of the acetylcholine, so there's the involvement of the enteric nervous system. So what will happen? There will be the release of the acetylcholine. Then before that, before of some stimulation like this irritation of the GIT tract, infection of the GIT tract, gut distension, taking the meal that distended the gut, what will happen? There is a release of the serotonin from the enterochromaffin-like cell present in the GIT. So what will happen? So then further, what will happen? The serotonin will act on the serotonin 4 receptor and the serotonin 3 receptor present in the serotonin 4 receptor and the serotonin 3 receptor, which are present in the in neurons of the enteric nervous system. So agonist effect on the serotonin 4 receptor will release the acetylcholine from the enteric nervous system. This acetylcholine will act on the muscarinic receptors present in the GIT tract, that increases the peristaltic movement. And the antagonist effect on the serotonin 3 receptor will also lead to the release of the antagonist effect on the serotonin 4 receptor, serotonin 3 receptor will also lead to the release of the acetylcholine. Acetylcholine will act on the muscarinic receptor, that increases the peristaltic movement. And the dopaminergic antagonist effect on the dopaminergic 2 receptor, that also leads to the release of the peristaltic movement. Okay. So any confusion till now? Should I continue?
Yes, sir.
Okay.
Yes,
now,
sir.
so CISAPRIDE and the MOSAPRIDE. So we are able to complete the metoclopramide and the domperidone. So metoclopramide, they are the centrally dopaminergic 2 receptor antagonist, and they are the prokinetic agent. Now the CISAPRIDE and the MOSAPRIDE. So what is the CISAPRIDE? CISAPRIDE and the MOSAPRIDE, they are only the prokinetic. They only shows the prokinetic effect. They only show the prokinetic effect. They only shows the prokinetic effect. No antiemetic effect, as do not block the I mean to say that they do not block the dopamine 2 receptor present in the chemoreceptor trigger zone or the dopamine 2 receptor present in the peripherally. They only shows the prokinetic effect. That means they shows the agonist effect on the serotonin 4 receptor and the antagonist effect on the serotonin 3 receptor. That's all. They do not block the dopamine 2 receptor which are present peripherally and the centrally. Okay, should I continue? Okay.
Yes, sir.
Now mechanism of action. So as we have already discussed earlier, agonist effect on they shows the agonist effect on the serotonin 4. They shows the agonist effect on the serotonin 4 receptor which promotes to the release of the acetylcholine. The acetylcholine will act on the muscarinic receptor present in the smooth muscles of the GIT, that leads to the increase in the prokinetic effect. So when the prokinetic effect is there, what will happen? That increases that speeds up the gastric emptying and increase the lower esophageal sphincter tone. Further, what will happen, you know better, no? Okay, that is the antagonist effect on the serotonin 4 receptor present in the GIT smooth muscle. Okay, etheric nervous system. Okay, again antagonist effect on the serotonin 3 receptor. Antagonist effect on the serotonin that depresses the inhibitory transmission. That means that facilitates the acetylcholine release from the enteric nervous system, that act on the muscarinic receptor present in the GIT smooth muscle, that increases the peristaltic movement. No dopamine receptor antagonist, no dopamine receptor antagonist, only the serotonin 4 receptor agonist effect and the serotonin 3 receptor antagonist. It's a simple, no? If you know about this physiology of this nausea and the vomiting prokinetic effect, so it's very simple. Should I continue?
Yes, sir.
Now, indications, very simple indications. Beside nausea and because we know that the nausea and the vomiting, they are the symptoms. So they are present in the certain diseases. So which type of the diseases? Gastroesophageal reflux disease. The main indication is the gastroesophageal reflux disease. Because what happened in the gastroesophageal reflux disease? Regurgitation of the food particles from the stomach to the esophagus. So as we know that the peristaltic, this CISAPRIDE and the MOSAPRIDE, they facilitates the peristaltic movement. So no minimum or no gastric contents are present. So and also there's an increase in the lower esophageal sphincter, tone of the lower esophageal sphincter. So what will happen? Minimum or no regurgitation of the food from the stomach to the esophagus. So it is used for the treatment of the gastroesophageal reflux disease. And other than that, it may be used in the non-ulcer dyspepsia and the constipation also. Non-ulcer dyspepsia and the constipation. Why in the constipation? Because it increases the peristaltic movement. What happened in the constipation? The mechanism of the constipation is a decrease in the peristaltic movement because it increases the peristaltic movement. That is also the reason it's used for the treatment of the constipation. Okay, we will discuss about this drug using the constipation in the coming lectures. Drug used in the constipation. So the main indication is the gastroesophageal reflux disease. It may use in the non-ulcer dyspepsia and the constipation. Okay, should I continue? Okay, now adverse drug reaction. Again, adverse drug reaction. We know that these drugs enhances the peristaltic movement. So definitely there will be the adverse drug reaction in the GIT tract. So what could be the abdominal cramps? But that will be the mild abdominal cramps and the diarrhea. That will be the mild abdominal cramps and the diarrhea because it increases the peristaltic movement. So because of the increase in the peristaltic, sometimes when the peristaltic movement increases more increase in the peristaltic movement more than the normal physiological peristaltic movement. So what will happen? That may produces the passes of the loose stools. That's called the diarrhea. So mild abdominal cramp and the diarrhea, they are the main adverse effects. Mild abdominal cramp and the diarrhea. The result, that is because of the over or enhanced massive peristaltic, because of the massive peristaltic movement. Okay. Prolonged QT interval sometimes. Okay, only in ECG, CISAPRIDE, and that is mainly by the CISAPRIDE. They prolong the QT interval that predisposes to the ventricular fibrillation. Okay, so they are the arrhythmia. They are the arrhythmia. Okay, that is not important. The important thing is the mild abdominal cramp and the diarrhea. That is because of the increased peristaltic movement. Okay, and the other minor side effects are the prolonged QT interval on the ECG. That will predispose to the ventricular fibrillation, but not by the MOSAPRIDE, mainly by the CISAPRIDE. The important thing is here is the mild abdominal cramp and the diarrhea. So important thing about the CISAPRIDE and the MOSAPRIDE is the mechanism of action, and at least remember their indication that is used in the gastroesophageal reflux disease, and the adverse effects, the main adverse effects, the mild abdominal cramp and the diarrhea. At least remember that. That is the important thing. Okay. Newer anti-emetic drugs. In brief, only newer anti-emetic drug. Prokinetic drug. They are the TEGASEROD. They are the newer prokinetic agent. Only remember, they are the serotonin 4 receptor agonists. They are the serotonin 4 receptor agonists. So what will happen? Serotonin 4 receptor. They are the newer prokinetic agent. Serotonin 4 receptor agonists. So what has happened? They enhances the release of the acetylcholine. The acetylcholine acts on the muscarinic receptor that increases the peristaltic movement, that reduces the nausea and the vomiting. Okay. Safe drug. There is the safe drug. And the indication is the irritable bowel syndrome. So basically, irritable bowel syndrome. This is the disease of the GIT. They are basically classified into irritable bowel syndrome with predominant of the diarrhea and the irritable bowel syndrome with predominant of the constipation. Okay, so irritable bowel syndrome is a disease of the GIT. Okay, that is predominant. There are basically two types. IBS. IBS is the abbreviated of the irritable bowel syndrome. That is the IBS predominant of the constipation and the IBS predominant of the diarrhea. This drug is used for the treatment of the irritable bowel syndrome. Other than the nausea and the vomiting, this drug is also used for the treatment of the irritable bowel syndrome with predominant of the constipation. With predominant of the constipation. Why with predominant of the constipation? Because this drug increases the peristaltic movement that subsides the that resolves the constipation. This should not be used. This drug should not be used for the treatment of the irritable bowel syndrome with predominant of the diarrhea. Okay. So other than the anti-emetic drugs, this drug is used. This drug is also used for the treatment of the irritable bowel syndrome predominant of the constipation. Okay, newer prokinetic agents, serotonin 4 receptor agonist effect, so increases the peristaltic movement, and the use for the treatment of the anti-emetic for the nausea and the vomiting, and also for the irritable bowel syndrome with predominant of the constipation. Okay, probably they will not ask question from this slide TEGASEROD, because the important part we have already covered in last 3 classes or today's classes. That is the dopamine receptor antagonist, serotonin receptor antagonist, antihistaminic drugs, prokinetic drugs, CISAPRIDE, MOSAPRIDE, and the metoclopramide and the domperidone. Okay, so that are the important part. That are the important topic. That are the important point. Important part of the anti-emetic drugs. These are only for the additional knowledge. That is for the additional knowledge. Okay. Again, substance P. That is a neurokinin 1 receptor antagonist. Okay, only the important thing is here, neurokinin 1 receptor antagonist. Okay, just remember that substance P, because last time they have asked the question in the multiple choice question, mechanism of action of the substance P. So what is the mechanism of action of the substance P? There's a neurokinin 1 receptor antagonist that is present in the chemoreceptor trigger zone. So at least only there. So which drug is the substance P and the neurokinin 1 receptor antagonist? Which the drug is the aprepitant. The drug is the aprepitant. Aprepitant is the drug as a neurokinin 1 receptor antagonist, or the substance P and substance P antagonist to the neuroreceptor 1 receptor antagonist. So that act by inhibiting the neurokinin 1 receptor present in the chemoreceptor triggers. That's all. Otherwise, it is used for the treatment of the cancer chemotherapy induced. So chemotherapy induced nausea and the vomit. Okay. So important thing to be remembered in this slide is the substance aprepitant is the substance P, and it is substance P, or it is the neurokinin 1 receptor antagonist. The substance P, or it is the neurokinin 1 receptor antagonist, and it is used for the treatment of the chemotherapy induced nausea and the vomiting. That's all. Otherwise, nothing is important here. If you want to add the additional knowledge, it is used orally along with the dexamethasone. Because dexamethasone is also used for the treatment of the chemotherapy induced nausea, vomiting. So along with the dexamethasone, it can be used orally for the chemotherapy induced nausea and the vomiting. Constipation and the fatigue are the major adverse effects. Only the important thing to be remembered here is the aprepitant are the neurokinin receptor antagonist, and they are used for the treatment of the chemotherapy induced nausea and the vomiting. Now the important point here, during the pregnancy. So what should be done during the pregnancy? Because the drugs should be minimized during the pregnancy. Any drug should be minimized to the at least no drug should be given during the minimized unless the absolutely required. No drug should be given during the pregnancy. So if the vomiting occurs during the pregnancy, so how that can be managed? So number one thing, if the drug, most of the vomitings that happens during the nausea and the vomiting, they are the mild and the self-limiting. They are subsided them. They are resolved themselves. No drug is required. They resolve themselves. They are the mild and the self-limiting. So important thing is that when the nausea and the vomiting happens during the pregnancy, the important thing is the reassurance. We need to reassure the patient. How we need to reassure the patient? We have to reassure the patient that these are the mild. This is the common condition. This is the mild, and the vomitings are the mild. And it is a self-limited. It will be resolved by itself. It's just a matter of the time. Okay. So vomiting is usually mild and the self-limiting. So no drug is required for that. So we can advise something how we can minimize the vomiting during the nausea and the vomiting, or we can prevent the nausea and the vomiting. So number one thing, avoidance of the fatty meal. Okay. And second is the advice to take the small and the frequent meal. That means Basically, we take the meal 3 times a day or the 4 times a day, but during the pregnancy, to minimize the nausea and the vomiting, or to minimize the morning sickness or vomiting, at other than the morning, if the vomiting occurs other than the morning, so we advise the mother, we advise the mother to take small meal, but take the meal frequently, 6 times, 7 times, 8 times, whatever that is. Take small meal, but take it frequently, and avoid the fatty meal. We need to reassure the patient. Or the placebo therapy, you know, the placebo therapy, we have already discussed about the placebo therapy. That is not a drug actually. There is psychodynamic therapy. There is a psychotherapy. There is a psychotherapy. Okay. If in case of the severe nausea and the vomiting, sometimes what will happen? Severe nausea and the vomiting may happen. That is called the hyperemesis gravidarum. That is called the hyperemesis gravidarum. If that happens, we need to give the drug. The best drug is the doxylamine. The best doxylamine along with the pyridoxine. We know that the pyridoxine is the vitamin B6. So doxylamine along with the pyridoxine is the safe and the effective drugs during the nausea and the vomiting. And the home remedy is the ginger. Ginger is the safe and the effective remedy in case of the mild vomiting during the nausea and the during the pregnancy. So important thing is here, when the vomiting happens during the pregnancy, no drug is required. Most of the vomiting are the mild and the self-limited. Only we need to reassure the patient. Okay, we have to advise the patient that mother, that we have to advise the not the patient, because pregnancy is not the disease actually. That's a normal physiological phenomenon. Okay, we have to advise the mother that it is because these conditions are common during the pregnancy. Okay, we have to advise the patient that we have to advise the mother that avoid the fatty meal, take the small and the frequent meal. And if the condition is okay, home remedy, ginger may be used as a home remedy. And if the condition is severe, then we may prescribe the drug, that is the doxylamine along with the pyridoxine. That's all about the nausea and the vomiting. Drug use in the nausea and the vomiting. So today's topic, we will continue our today's topic, some part of the today's topic, that is the anti-helmintics. So I think you better know about these terms, anti-helmintics, the drugs. So what is the anti-helmintic? So we know about the worms. We know about the worms infection. We know about the worm infections. Okay, can you hear me?
Yes, sir.
Okay, yes, please. Okay, yes, please. So anti-helmintic drugs, anti-helmintic drugs, the drugs which are used for the treatment of the excuse me. So drugs which are used for the treatment of the worm infection. The drugs which are used for the treatment of the worm infection, that is called the anti-helmintics. That are called the anti-helmintics. Okay. So we know about the worm infection. So drugs which are used for the treatment of the worm infection, that is called the anti-helmintic drugs. So before knowing about the anti-helmintics, we have to know about the different types of the helminths or the worms. So I think this we have already known about this nemathelminths and the platyhelminths. So nemathelminths, what are the nemathelminths? So because they are called the nemathelminths because of their structure, their body structure is, they are the round-bodied worms. They are also called the nematodes. Round body worms. They are the round body worms. The body structure is the rounded. That is the round bodied worms. So what are the different? Ascaris lumbricoids. You know about the most important, most common is the Ascaris lumbricoids, round worm. And the disease caused by the Ascaris lumbricoid is called the ascariasis. Or the roundworm infection. In layman's term, that's called the roundworm infection, or the scientific term is the ascariasis. That's called the Ascaris lumbricoids, roundworm. Okay. Second is the hookworm. So there are the two types of the common hookworm: Encyclostoma duodenale and the Necator americanus. And the infection caused by the hookworm, that is called the encyclostomatitis. Okay. In simple language, we can say the roundworm, hookworm infection. Okay. Encyclostoma duodenale and the Necator americanus. Enterobius vermicularis, that's called the pinworm also. And the disease caused by the pinworm, infection caused by the pinworm, that's called the enterobiasis. That's called enterobius vermiculum. And the whipworm, that's called the trichuriasis. And the disease caused by the trichuriasis called the trichuriasis, whipworm infection. And I think we know about this term filariasis. as a Wucheria bancrofti and the Wucheria molli. I think we have discussed about that. So drug of choice for the filariasis is the diethyl carbazine. So we will also discuss about that drug in this topic also. So classification of the helminths worms, they are the nemat helminths and the platyhelminths. So nemat helminths, they are the round-bodied worms. They are also called the nematodes. Ascaris lumbricoids, roundworm. Encyclostoma duodenale, Necator americans, they are the hookworm. Enterobes barbicularis, the pinworm. Trichuris, the whipworm, and the Filarias, Wucheria bancrofti. And the Brucea molli, the infection caused by the Ascaris lumbricoids or the roundworm infection is called the Ascariasis. Hookworm infection is called the Encyclostomatiasis, and this pinworm is called the Enterobiasis. Whipworm is called Trichuriasis, and the Filariasis, that's the infection of the Wucheria bancrofti or the Wucheria bancrofti, basically the Wucheria bancrofti. Now the platyhelminths, they are flat-bodied worms. They are called the flat-bodied worms. Platyhelminths, they are called the flat-bodied worms. Trematodes and the cystodes. Okay, trematodes are the blood flukes. Zuka, in Nepali, that's called the Zuka, no? Blood flukes that is present in the forest. Zuka, blood fluke, okay? And the liver fluke. That's called the blood fluke and the liver fluke. Trematodes, blood fluke and the liver fluke, okay? So blood fluke causes the schistosomiasis and the liver fluke causes the clonariasis, okay? So trematodes, they are the blood fluke and the liver fluke, okay? And the cystodes, this one is the important, okay? Flat-bodied form, Tinea saginata, that's the beef tapeworm, and the Tinea soleum, that's called the pork tapeworm. Beef tapeworm and the pork tapeworm, okay? Platyhelminths are the flat-bodied worms. Trematodes and the cystodes. Trematodes are the blood fluke and the liver fluke, and the cystodes, they are the Tinea saginata and the Tinea soleum. Tinea saginata is the beef tapeworm, and the Tinea soleum is the pork tapeworm. Okay. So this is just the picture. This is just the picture of the high resolution picture of the different types of the worms, common worms. So this one is the round bodied. These two are the round bodied worm. So this one is this round bodied. This one is the nemat helminths. This one is also the nemat helminths, and this one is the platyhelminths. Round bodied worm. So this one is the round worm. This one is the hookworm. We can see the hook here, no? Hook like structures are present, no? That's called the hookworm. Okay, and this one is the platyhelminths. We can say the Tinea saginata, could be the Tinea saginata or the Tinea soleum. Flat bodies is there, no? Okay, so just for the alikati bujhnalai matra yo चाहिँ and khasai nothing is important here, only the round bodied worms, roundworm, hookworm, that is also the round bodied worm because the hook like structures are present, and the flat bodied worm, that's called the probably this is the Tinea saginata or the Tinea soleum. So nemat helminths, these two are the nemat helminths, and these two are the platyhelminths. These are the platyhelminths. Okay, now classification of the drugs which are used for the treatment of the worm infection, or we can say the anti-helmintic drugs. Okay, the most important, there are two drugs. Most important, benzimidazoles. The most important drug is the benzimidazoles, albendazole, mebendazole, and the albendazole. Okay, the important drugs are the albendazole and the mebendazole. If you are not able to remember the albendazole, that's okay. At least remember the albendazole and the mebendazole. Okay. And the other drugs are the diethyl carbazine. Okay, we have already discussed about that in first year. Also, we will discuss about this in this topic also in brief. Only praziquantel. Okay, niclosamide. Ivermectin. Okay, piperazine, and the other drugs are the levimazole and the pyrantel. Levimazole and the pyrantel. Okay, important drugs is the benzimidazole, albendazole, mebendazole, and thiabendazole, diethyl carbazine, praziquantel, okay, niclosamide, ivermectin, okay, piperazine, and the other levimazole. Okay, this something I think you might have heard about this ivermectin. It's a relation with the antiviral drug also. It has the property to kill the bacteria, to kill the virus also. So probably in Bangladesh one of the some of the patients with the COVID-19, they are treated with the ivermectin along with the tetracycline, and the patient was the outcome of the patient was improved. So ivermectin is also considered as the we will discuss about that in the coming classes about when we will discuss about this ivermectin, we will also discuss about that part also. But I have to say that this ivermectin is also being used for the treatment of the COVID-19 disease because they have the antiviral properties also. Okay, so important thing is here classification. The benzimidazole, the drugs are the albendazole, mebendazole, and the thiabendazole. Other drugs are the diethylcarbazine that is used for the treatment of the filariasis, and the other anti-helmintic drugs are the praziquintal, niclosamide, ivermectin, piperazine, and the others are the levamisole and the parental pamide. Okay. So benzimidazole, the drugs are the albendazole, mebendazole, and the thiabendazole. We have already discussed about the important thing with the important thing with the albendazole. This benzimidazole is the broad spectrum anti-helmintics. Broad spectrum anti. It covers almost all the worm infection. That means it covers almost all the worm infection like the round worm, pinworm, weepworm, hookworm, and also this Taenia cyzinata for the Taenia solium. That's called the cystic sarcosis. That's called the cystic sarcosis. Okay. So broad spectrum anti-helmintic. The important with the benzimidazole is the broad spectrum anti-helmintics. So during the pregnancy, so important thing is that during the pregnancy, okay, nausea and the morning sickness, the common problem during the pregnancy, probably during the first trimester of the pregnancy, first trimester banale, early 3 months of the pregnancy is called the first trimester of the pregnancy. So treatment of the vomiting, benzimidazole, the drugs that comes out of the benzimidazole are the albendazole, mebendazole, and the thiabendazole. So albendazole, mebendazole, and the thiabendazole. Broad spectrum antibiotic. They are broad spectrum anti-helmintic. Broad spectrum anti-helmintic. They are the broad spectrum anti-helmintic. Okay. Now the pharmacokinetics of the benzimidazole. That's pharmacokinetics of the benzimidazole. So these drugs orally absorbed. So oral preparation is only the oral preparation is available. Benzimidazole derivative, only the oral preparation is available because these drugs, they are the orally absorbed. Oral absorption is variable. It is believed that but the oral absorption is variable. Pharmacokinetics, benzimidazole derivative, albendazole and the mebendazole, they are given by the oral absorption. They are given by the oral preparation is available. Route of the administration is the oral route. Okay, but variable oral absorption. So to increase the oral absorption, if it should be given with the fatty meal. That means if it is taken with the fatty meal, the absorption of the this drug will be increased. The absorption of this drug will be. So it should be taken with the fatty meal like the milk and the other fatty meals like the milk and the other fatty meals. Okay, so that increases the absorption with the fatty meals. Okay, albendazole, approximately 70% of the albendazole binds to the plasma protein. Approximately 90% of the mebendazole binds to the plasma protein. Plasma protein as well as the tissue protein. Metabolism in the liver, and it will be metabolized to the active metabolites. They are the sulfoxide. Active metabolites, that are the sulfoxide, and the excretion in the urine. Okay, so nothing difficult in this slide. Only the important is oral absorption. Orally, these drugs are given oral route, but the oral absorption is variable. So to increase the oral absorption, it should be given with the fatty milk. To increase the oral absorption, it should be given with the fatty milk. Okay, that is the important thing here. Okay. Now the mechanism of action. So I did not find the appropriate schematic diagram for this mechanism of action, but I will try to explain it as far as clearly I can. Okay, benzimidazole derivative. So we know that the beta tubulin and the microtubules and the beta tubulin. So what are the microtubules? Beta tubulin assembled together. The beta tubulin assembled together. We can say the beta tubulin of the parasites. We can say the beta tubulin of the parasites, not the human being. Beta tubulin of the parasites, they assemble together to form the microtubules. And what worms. Okay, I will say the parasite. Okay, when I will say the parasite, remember that is the worm. In parasites, beta tubulin polymerize together, or we can say assemble together to form the microtubules. And what the microtubules in the parasite? The role of the microtubules in the parasite is the glucose uptake, to uptake the glucose. And why that glucose is required? The glucose is required for the glycogen stores, for the ATP formation, that is for the energy formation, and for the different metabolic pathway, I will repeat it again. Physiology. This is the physiology of the worms or the parasites. Beta tubulin, they assemble together. Beta tubulin assemble together to form the microtubules. And what of the parasite? So what is the role of the microtubules of the parasite? The role of the microtubules of the parasite, microtubules in the parasite is to uptake the glucose. And why that glucose is necessary? The glucose is necessary for the energy dependent mechanism in the body, for different metabolic pathway in the body, for the formation of the ATP and for the formation for the store of the glycogen in the parasite. That is done by the microtubules. Okay. Now, what is the mechanism of action of the benzimidazole? So benzimidazole, it binds to the parasite beta tubulin. With high affinity. It binds to the parasite beta tubulin with high affinity. Okay. And when it binds to the beta tubulin with a high affinity, it prevents the polymerization of the beta tubulin. Or we can say the assembly of the beta tubulin. When there is the inhibition of the polymerization of the beta tubulin, what will happen? There is a breakdown of the microtubules, resulting in the breakdown of the microtubules. When there is a breakdown of the microtubules, what will happen? There is the selective and the irreversible. When I say the selective, it is the important point here: selective and the irreversible inhibition of the glucose uptake. Selective and the irreversible inhibition of the glucose uptake. The end result will be the depletion of the parasite glycogen store, reduced formation of the ATP, and the disruption of the metabolic pathway, and ultimately that will lead to the parasite death. That is the mechanism of action of the benzimidazole. I will repeat it again. Benzimidazole, they bind to the parasite beta tubulin with the high affinity. When they bind to the beta tubulin with the high affinity of the parasite, there will be the inhibition of the assembly of the or the polymerization of this beta tubulin. So that will result the breakdown of the microtubules. And when there is a breakdown of the microtubule, there is selective and the irreversible inhibition of the glucose uptake by the parasite. Okay, and the end result will be the depletion of the parasite glycogen stores, reduced formation of the ATP, disruption of the metabolic pathway that will lead to the parasite. Okay, the important thing that benzimidazole have very low affinity to the human beta tubulin. Benzimidazole have very low affinity to the human tubulin. So minimum effect in the human beta tubulin. Minimum effect in the human being, or we can say the mammalians. Minimum effect in the mammalians. Okay, they binds to the beta tubulin is the higher affinity in the parasite. Minimum effect in the human being because they have the low affinity to the human beta tubulin. The important thing is they inhibit the assembly of the beta tubulin that will break down the microtubules, and we know that the microtubules is required for the energy dependent mechanism in the albendazole. So when there is the breakdown of the microtubules, no glucose will be uptake. When no glucose will be uptake, so what will happen? Depletion of the glycogen store will be there, reduced ATP formation will be there, reduced metabolic pathway will be there. That will lead to the ultimately parasite death. Now the indications. Okay, we know that anti-helmintics, albendazole, they are the broad spectrum anti-helmintics. So they are used in all type of the infection, most of the type of the infection. DOC, drug of choice in the roundworm, ascariasis, hookworm, encyclostomatiasis, whipworm, enterobiasis, pinworm, whipworm, trichuriasis, and the pinworm, that is called the enterobiasis. Okay, if it is difficult to remember the scientific name, remember the infection of the roundworm infection, hookworm infection, whipworm infection, and the pinworm infection. And albendazole is also used for the prevention of the roundworm infection. Okay, that is present in the regularly. This drugs is given regularly by the Nepal government. Okay, by the Nepal government also. So for the treatment of during while providing the treatment of this filariasis also. Okay, but the Nepal supplemented by the Nepal government also. Okay. Drug of choice in the cystic sarcosis. That is the Tinea solium. It's Tinea saginata. Tinea solium. That's called the Tinea solium. Tinea saginata. Tinea solium. That is the tapeworm infection. And the drug of choice in the Echinococcus. That is caused by the Echinococcus granulosa. It's also called the additive disease. Okay, albendazole is used for the treatment of the roundworm infection, hookworm infection, whipworm infection, the pinworm infection. Drug of choice in the cystic sarcosis and the drug of choice in the Echinococcus. That is also called the additive disease. And the mebendazole Same roundworm infection, hookworm infection, pinworm infection, and the weakworm infection. Okay, infection is there. Not in the roundworm. Infection is there. Okay. I think everything is clear. Nothing to explain in detail. Everything is clear here. Okay. Okay. Now, dose of the albendazole. No, dose of the albendazole for the roundworm. If more than 2 years, 400 milligram per oral single days. For the less than 2 years, 200 milligram per oral single dose. Okay. For the roundworm, dose for the albendazole. Albendazole. That's for the albendazole. Okay. More than 2 years, 400 milligram per oral single dose, and the less than 2 years, 200 milligram per oral single dose. Okay. Dose of the mebendazole for the roundworm, 100 milligram per oral BD for the 3 days. Now, Ramita, which drug will you prefer? अब भगवानले अब कुन राउन्ड के albendazole दिने कि mebendazole दिने कुन चाहिँ खाने अब 400 milligram single dose or the 100 milligram per oral BD for the 3 days? Six drugs or the one drug? Single dose, no?
One drug.
One drug is the better, no? Okay, because the dose are there, because their dose is there, no? 400 milligram per oral single dose, 400 milligram per oral single dose. Roundworm, albendazole and the mebendazole, efficacy, if you talk about the efficacy, not significantly different. Only the thing is that single dose, 400 milligram single dose, and the 100 milligram per oral BD for the 3 days for the roundworm, mebendazole. Okay. I think it's a very simple. Okay, in case of the cystic tinea solium, and albendazole should be given with the glucocorticoids to prevent the inflammation and the allergy reaction. That is the in case of the cystic sarcosis, albendazole is given for the treatment of the cystic sarcosis. But what will happen? They kills the parasite, they kills the tinea solium, they kills the tinea solium. When they kill the tinea solium, what will happen? There's a denaturation of the protein. Of the tinea solium. So that becomes a foreign body. That protein becomes a foreign body to the human being. That may cause the inflammation, allergic reaction, inflammation. No. So to prevent that inflammation, that may happen because of that might have happened because of this denaturation of the protein of the tinea solium. So we need to give the glucocorticoids along with the albendazole to prevent the inflammation and the allergic reaction. Got the point? Any confusion? The dose of the albendazole is for the roundworm, more than 2 years, 400 milligram per oral single dose, less than 2 years, 200 milligram per oral single dose. Okay. And dose of the mebendazole for the roundworm, 100 milligram per oral BD for the 3 days. Okay. And in case of cystic sarcosis, albendazole should be given with the glucocorticoids to prevent the inflammation and the allergic reaction that might have happened because of the denaturation of the protein of the tinea solium. Cystic sarcosis is cystic sarcosis is called the infection with the tinea solium. If that infection reaches to the brain, that is called the neurocystic sarcosis. That is called the neurocystic sarcosis. Adverse effects generally well tolerated. Not important. Only the minor side effects like the abdominal discomfort, nausea, vomiting increases the aminotransferase level. That is not significant. Okay, generally well tolerated. Contraindication. It should not be given in the pregnancy for the long-term use. It should not be given for the pregnancy for the long-term. Like for the neurocystic sarcosis, the drug should be given for the 1 month, for the 1 month or even more than the 1 month. So it should not be given in that manner. For the roundworm infection, single dose can be given, or if single dose can be given. Otherwise, it should be contraindicated in the pregnancy for the long-term use. So we can see here 2 slides are there, no? A and B. This is CT scan. This is the CT scan of the neurocystic sarcosis, CT scan of the neurocystic sarcosis. So abnormality is here, no? Here, this one is the normal part. Abnormality. You can see this hyperdense area, no? Black area. So this one is the plain CT scan. This one is the plain CT scan, and this one is the enhanced CT scan. Contrast enhanced CT scan that happens after, that occurs after giving the radiolucent type. That is by giving the radiolucent type. So you can see here, no? This one is the black part, and we can see the hazy ring-like structure, no? So this black part is the inflamed part, and the hazy ring-like structure, that is the cyst of the tinea solium. In plain CT scan. And after the dye is given, radiolucent dye is given, now it one become the more prominent. The ring-like structure become the more prominent. This one is the ring-like structure, becomes the more prominent, and this black part is the inflammation. That is the inflamed area. This is the inflamed area. So that is the neurocystic sarcosis. That is the neurocystic sarcosis. Tinea solium, neurocystic sarcosis, tinea solium. Okay. So what could be the causes of the neurocystic sarcosis? Neurocystic sarcosis, causes of the neurocystic sarcosis, uh, like someone says that the undercooked undercooked pork meal or undercooked meal. Not it is because of the undercooked pork meal. Nowadays, the important thing is that the important cause is the consumption of the green leafy vegetables, not uncooked green leafy vegetables, uncooked, or consumption of the green salad, if it is not cleaned properly, So to avoid the this neurocystic sarcosis or the cystic sarcosis, the important thing is avoid eating the green salad which are available in the restaurant, which are available in the party palace or the party everywhere. Okay, so the important thing important thing is here. So this one is the ring enhanced lesion. This one is the ring enhanced lesions. Ring like structure, that is the cyst of the tenosolium, and this is the case of the neurocystic sarcosis. And this black part is the surrounding black part is the inflammation of the brain. And the cause for the neurocystic sarcosis, the consumption of the green salad or the undercooked or the uncooked green leafy vegetables, and then we can say the consumption of the undercooked pork meal or the pork meat and the